Welcome to the United States-based segment of the Boma Global COVID Summit. I'm Dr. Daniel Kraft. I'm a physician based in the San Francisco Bay Area. I'm the faculty chair of medicine at Singularity University, run a program called Exponential Medicine. Know many folks on the Boma team. And I'm going to kick it off with my friend Dr. Divya Chander, who is a physician, neuroscientist, Harvard, UCSD, UCSF trained, practicing anesthesiologist and neuroscientist, has been a partner with me at Singularity University as the chair of neuroscience, while I've chaired medicine, and has been playing an active role on many realms across the COVID landscape, and is going to share a bit about what's happening in the space. We're going to wait a minute for her to come on. Looks like they've popped up the wrong person, so we're going to try and get Divya Chander up. If she is delayed, I'll go on and start with my element. I'll just say at a high level as we start this section that I think we've all experienced that we have a whole new set of possibilities that are emerging, a whole new set of collaborators, and it gives us an opportunity to really rethink and reimagine not just our address to viruses and pandemics, but hopefully addressing other grand challenges, but particularly to sort of rethink and reimagine healthcare. So I think while we're waiting for Divya to pop back up, I think I'm going to hand it over actually and move a bit ahead to Dr. Margaret Liu, and we're going to talk a little bit about what's happening in the vaccine space. Because actually we want to sort of get to a vaccine element, and hopefully Dr. Margaret Liu is ready. She's often been coined as sort of the mother of DNA vaccines. She's been a researcher studying gene expression, immune responses for many years, trained at Harvard, was a professor at Karolinska, and really has helped found the field of DNA vaccines, as she'll discuss. So I think we're giving a little surprise, and we're going to move Lena up front to give us a little taste of what's happening across the vaccine space. So over to Margaret. Oh, Divya's back. All right, well, maybe the one we'll stay on schedule.
I'm back.
The challenge.
It looks like I got kicked out of the platform for a moment.
All right, well, welcome, Divya. I just made an introduction to you earlier. Divya, again, chair of neuroscience at Singularity University, MD, PhD, neuroscientist, and practicing anesthesiologist. And Divya is going to take us on about a 25-minute journey into what's the cutting edge of knowledge about COVID, and then we'll go from there. Over to you, Divya.
Thank you. Hi, so good evening, United States, and wherever you are in the world, whatever time zone we're in. We are trying to be super good with time. So if any of this is interesting to you and you do want to know more, I've actually been building a website where you can find additional information that will be constantly updated. So let's start, and let's just ask ourselves for a moment what a virus is. Viruses happen to be somewhere on the edge between life and not life. They can't reproduce. They can't make more copies of themselves. So their code of life is encased in this protein shell. And in order to make more copies of themselves, they have to infect other host cells. And that's exactly what this particular coronavirus is doing and why it's getting us sick. Now, what you can see in this image is a 3D structure of the coronavirus. And there are a number of these little red things that are sticking out. These happen to be spike proteins. And those spike proteins are what the virus actually uses to attach to human host cells. And very recently, the crystal structure of these spike proteins has been solved. And you can see here a 3D view of a virus that is studded with these kinds of spike proteins. And what the proteins do is they bind to a receptor in human cells called the ACE2 receptor. And we have an enzyme that now breaks apart the spike protein and it allows the virus to be internalized into human cells. So that's kind of the life cycle of it. Once it gets inside a human cell, it makes more copies of itself. And then after it makes more copies of itself, it's released into the human host and it destroys the cell that it just invaded. Now, this brings us to some really basic things that we can talk about. One is, how can we actually test for that? So one of the things that you can do is look for little pieces of the code of the virus, the code of life of the virus. So for instance, we can take a swab from someone's nose or from someone's throat, and we can get that and we can amplify the viral RNA and we can look for pieces of that. We can also go into the bloodstream and look for antibodies that the human host may have formed against the virus. And finally, we might be able to directly search for the sequences themselves. So let me give you an example of what these three things look like. So what you can see here, this is a picture from South Korea. And as many of you heard, they've had exceptional testing capabilities. And one of the ways they were able to do this is through these drive-through test sites. And you can see a South Korean health worker here, and she is covered head to foot in essentially hazmat gear. This is level 3 protection. And she's putting a swab up someone's nose in order to get a nasopharyngeal sample. And she's going to do this amplification of viral RNA in order to look for it. Now, in the United States, we've had a bit of a problem with testing. And one of the reasons for this is that we were not able to deploy tests that had not been approved by the Food and Drug Administration. So late in February, they approved something called emergency use authorization, which allowed tests that that worked but had not yet been through the entire FDA testing cycle to be deployed. And very quickly, things have gotten a bit better. Here you see a testing station in New Rochelle, New York, and you can see a healthcare worker who is also covered getting a nasal swab from one of the subjects in her car. And then Roche actually came up with an even faster version of this test, and they were able to get rapid FDA approval for it. So with a test like this, we may actually increase testing capacity in the United States and globally far above our current capacity, up to millions of tests a month. Now, I had mentioned to you the possibility of using antibodies. So why is that important? Instead of looking for an active infection, which is what this PCR test looks for when we do these nasal swabs or these oral swabs, what a blood test will do is it'll actually look to see if somebody has been exposed to the disease and formed immunity against it. And there is a preprint that has just come out in bioRxiv that has actually published how to do this kind of blood test in order to detect for SARS-CoV-2 seroconversion. Now, this is especially important because how is it that we would know, number one, how many people have true immunity within the population, and also how many people have been infected, whether or not they ever showed symptoms. So this is going to, I think, revolutionize our ability to track the virus. Finally, I had mentioned that there are some technologies that are out there that can directly look for the viral RNA. And this technology is known as CRISPR. So many of you may have heard of CRISPR in the context of things like gene editing. And what CRISPR is an enzyme system where it's a little bit like the command find function in Word. It actually looks for a particular sequence. And in the case of CRISPR gene editing, it's looking for a misspelling in our DNA that can be corrected. Well, both Mammoth Biosciences, which is based in California, and Sherlock Biosciences, which is based in Massachusetts, have used a slightly different version of this enzyme system that can search for this viral RNA and for these segments of viral RNA. And in the case of Sherlock, they have developed almost the equivalent of a point of care test. In other words, if the CRISPR system detects there is any coronavirus RNA in the system, it will actually cause a strip of paper to change color. So this is going to also increase our testing capacity in the United States and elsewhere in the world. So let's move on to the idea of vaccines. So before we were talking about testing, how do we track the virus? How do we figure out who we might need to isolate and protect? In terms of vaccines, and I'm not going to say as much about this because I know that we have somebody coming online who's really going to delve into this. But the important things to note here is that the technology we have today has really changed our ability to build vaccines. The Chinese published the genetic code in mid-January. And as soon as that happened, multiple companies were able to go to work on vaccines. And that's because they were using things like RNA and DNA vaccines. Moderna was one such company, and they had developed a possible candidate within 42 days of getting that published sequence. And that has made investors sort of rush into the space and to invest in this kind of biotech. Just so you know that there are other public funding mechanisms available. There are also accelerators that are coming online. Bill Gates has combined with the Wellcome Trust and with MasterCard to found a new accelerator for developing vaccines. And in the last couple of days, Novartis has just come on board, and they have over $150 million towards this effort. Now, this is just a very small list of some of the companies that are working in this space. And that brings us to the idea of therapeutics. So why therapeutics? Until we develop a vaccine, until we can fully test it for both efficacy and for safety in the population, we need to sort of stop this virus in its tracks and at least cure the people who are developing symptoms, especially severe symptomology. So what approaches might we take? This turns out to be actually a very, very interesting space. There are a few ways that we can actually block viruses. So what you see in this particular preprint is an example of the coronavirus, and that's here up at the top. And you can see it's sort of studded with those spike proteins, and you can see its RNA, its code of life in the center. And what it's doing is it's trying to bind to the ACE2 receptor on this human cell membrane. And this cell membrane basically looks like a set of sort of lollipops kind of facing towards one another. Now, the ACE2 receptor is, once it's recognized, this spike protein has to be broken by this particular enzyme over here. So one way we can stop this virus from infecting humans is to block the enzyme that helps it get in. And that's exactly what this German group is trying to do. They're trying to repurpose a drug that has been used to treat pancreatic disease in Japan, which means that we know something about its safety and efficacy profile. And it's trying to repurpose it to block the coronavirus from entering human cells. So what are some of the other approaches? This is actually also a preprint coming out of China. And let's list a number of drugs that they're trying. And these are all antiviral drugs. And antiviral drugs, essentially, somewhere in the system, they stop the life cycle of the virus in terms of its replication. So remember, I told you that viruses can't make copies of themselves, and that's why they find host cells. Once they enter a human host cell and take over the machinery to produce more copies of themselves, they can then kill the cell and then expel more viral copies. What these various drugs are doing is blocking the ability, in many cases, for the RNA polymerase, that's the enzyme that makes more copies of the RNA, to work. And so we can block the virus making more copies of itself. And this is one example. This is a promising example. And some of these drugs have been repurposed from Ebola or from HIV. And in fact, there's a very, very interesting case. There were a couple of Italian tourists who were visiting Rajasthan, India, and they both tested positive for COVID-19, and they were given a combination of HIV antivirals, a swine flu antiviral, but also malaria drugs. And one of the two of them converted to becoming negative very, very quickly. So what's that about? We'll take a look at this graph. This is another preprint. This one comes out of France. And what you see on the y-axis is the number of people who are infected. So at day 0, let's just call it 100% of the people we're looking at. And they were given drug therapies, either this anti-malarial drug alone, or the green triangles, and an anti-malarial drug plus an antibiotic. And you can see that the people who got just the anti-malarial drug, by day 3, their viral titers began to go down significantly. And if they got a combination of the two, by day 3, many of them had something like only 10% of what their original viral burden was, and within 5 days they were completely cured of the virus. So this holds a lot of promise, both alone and in combination. And because of this, a few days ago, Novartis announced that they would be donating up to 130 million doses of hydroxychloroquine, which is the anti-malarial drug, in order to support this global effort. Now, there are other approaches to this. So In Silico is a company that leverages artificial intelligence for drug discovery. And they have now focused their efforts to doing that for COVID-19. And later in this particular broadcast, you'll be seeing a very, very short message from the CEO of this company, how they've been trying to sort of take this platform and move it into to discovering new drugs for to solve for COVID-19. Another example of what we might be able to do. So at Stanford, there is a group called Folding at Home. And what they do is they crowdsource computing capacity. And in this particular case, what they're trying to do is look at the spike protein that the coronavirus uses to attach to human cells. Now, that spike protein doesn't just stay in one form. It bends, it wiggles, it changes, and it takes a lot of computing power to figure out what these changes look like. But once you know what the changes look like, you can actually find things that may be able to bind to that structure. So again, they're crowdsourcing. And in fact, all of you could go to foldingathome.org and you could donate your computer's processing time towards this effort. So this brings us to an interesting point. How do we actually track pandemics? Well, this is a graph I pulled from the Johns Hopkins website. They've been doing some of the best tracking in the world. They're pulling data from the CDC, from WHO, but from everywhere essentially. And this graph was pulled from March 15th, so that was last week. And what you can see here is that China's at the top of the list in terms of the number of confirmed cases, and the U.S. is about 7th on this list. And there have been 6,500 total deaths and about 76,000 people recovered. Well, this was the graph just pulled yesterday, and you can see that the number of cases has more than tripled. And look at where the US has moved. We are 3rd on this list now, only just after Italy. So it shows you that things are progressing at an incredibly fast rate. So what can we do for tracking? Well, in some countries, we can deploy things like smartphone technology. Flu tracking is an app that was developed in Australia. And once somebody signs up for it, people in Australia and New Zealand can basically enter their symptoms on a daily basis during flu season, and they can figure out who is developing symptoms. And if somebody looks like they're developing the flu, they can not only track them, but they can figure out who they've been in contact with and who they may need to isolate. I mentioned to you that there's now a new antibody test for discovering whether or not someone has been exposed to SARS-CoV-2 or this coronavirus. And that will also be helpful for us in terms of tracking people who have been exposed and people who are now immune. This is a very, very interesting website. This is called nextstrain.org. And what they do is they're able to track what's happened, how the virus is moving and where it's going by looking at how the genome of the virus is mutating in real time. And so what you can see is that some of these spots over in China where the virus originated, that's sort of the base of the tree. And as the virus moves around, the spots, for instance, in the United States are red, and they've diverged quite a bit from what you see in China. But one way you might use this for tracking is to say, well, you've got 2 people in Washington state who are sick and who've tested positive. And if you sequence the viral genomes, you may find that one of the people got the virus by being exposed to somebody else in Washington state, but another person actually acquired it through travel, because you can compare how different or similar those genomes are. And that brings us to this point in pandemics of understanding exponential growth. I am not going to show you the animations, but there are some really, really good interactive animations on the New York Times website. But essentially, there's something called an R0 number, and that's how infective the virus is. So the seasonal flu has an R0 number of about 1.3. That means for every one person who has the flu, if they're exposed to other people, they typically will give it to one other person. And that means after 5 cycles of this, maybe 45, 50 people will be infected. the coronavirus has an R0 value of between 2 to 3. And let's assume it has an R value of about 2.5. Within 5 cycles, more than 500 people would be infected. And that's why it's spreading so quickly. What you see here from, again, that Johns Hopkins website is that from January to about mid-February, this period they call the China period. This is when the number of cases were increasing in China. And it has maybe a mild sort of hint of an exponential curve, but China jumped on this very, very quickly. However, not so quickly that cases didn't get out of China. And this period, which is the out of China period, you can see how that exponential curve has been taking off since mid-February to early March. And at the moment, this is where we are in the US. And don't forget, this is based on only the number of cases we have been able to test based on the number of tests we had, for every 2 people who test positive within a couple of week period, you can assume that there are almost another 200 people who are coronavirus positive. But also just take a look at the curves to the right. And I just pulled these from that website a couple of hours ago. Active cases and the total number of deaths in the United States are also tracking exponential curves. So they're increasing very, very quickly. Which brings me to this. I know people have been talking about recommendations for how to contain the spread. It's too important not to say it again. So we know about washing your hands for 20 seconds. This is one of many amazing TikTok videos that are trying to teach people how to avoid getting the virus and how to avoid spreading the virus. The most important piece of it, though, is this social distancing piece of it. And let me just show that to you in the context of exponentials. So take a look at this curve here. These are the total number of cases that you see in black if we do not practice social distancing. And so far, we have been on that curve in the United States. If we were to start social distancing about 19 days after this is discovered, which is what you see on this sort of this greenish line, you can see we dropped the number of cases by almost 50%. Waiting 1 day to bring into place social distancing regulations actually increases the total number by another 40%. So exponentials can work against us, but they can work for us if we are able to do this. And here is a graph from the New York Times of the changes in the number of travel each day. March 11th, they started talking about things like social distancing, but you can still see that people in yellow basically reflects the average amount of travel in each state. And they're not changing very much. In fact, in some states, people are traveling more than normal. March 17th in the state of California and several other places, there were rules put into place in certain counties that asked people to start sheltering at home. And you can begin to see that the amount of travel has decreased significantly from the 17th of March to the 20th of March. Not in all states, though, and we need this to be kind of a universal thing. And the reason for this has a lot to do with flattening the curve. Now, we heard from Dr. Sue in New Zealand, and she's really one of the people who's made this graphic go viral, but this is one of the original graphics from the CDC. What you see is if we don't practice social distancing, the number of daily cases will continue to peak. And the problem is that if it goes beyond this dotted blue line, which is the capacity of our hospitals to take care of the very sick, we will be overwhelmed and we're going to experience a lot of deaths. However, if we do all those interventions like washing our hands and the social distancing, we may be able to maybe not decrease the total number of people who get the virus, but the rate at which they get the virus. So we'll decrease that R0 number. And this is incredibly important because if we can bring it to below that line, our healthcare capacity will continue. And why is this so important? Take a look at this graph. This comes from the Lancet. And what you see here is this is data that comes out of China now. On this figure A over here, you can see that there's mortality on the y-axis, and they're comparing it in Hubei, which is where Wuhan is, and other provinces. And what you find is in places where there are too many cases, the mortality increased. Not because the virus was more dangerous, but because the healthcare system couldn't cope with the number of cases. And you see that really well in Figure B. The number of cases per 10,000 people in the population was higher in Hubei province than the other provinces. And that's really where you saw most of the mortality. This is the United States. We're supposed to have one of the best healthcare systems in the world, but we were not prepared for this. We don't have enough masks. We don't have enough protective equipment in general, and people have been hearing a lot about this. People are being told not to hoard masks or not to wear masks unless they're symptomatic. But in my specialty, I'm an anesthesiologist and critical care doctor. There is an even bigger problem. And that is we are running out of resources to keep especially the very, very sick alive. We don't have, for instance, enough ventilators to support all these people. And healthcare rationing is becoming a thing. These are videos made by anesthesiologists to teach other anesthesiologists how to intubate a patient who is known to be COVID-19 positive, both so they don't contaminate the room, but also so they don't contaminate that particular physician or practitioner who is trying to intubate the patient. And whereas in the United States, we are wearing, let's say, we're wearing some eye goggles, maybe an N95 mask if you can get it, and a gown and gloves. It was quite different in Wuhan. You can see here, this is a preprint from an article and in anesthesiology. And what was really interesting is that the Chinese anesthesiologists have been incredibly active in sharing their experiences with the virus. You can see they are in full level 3 gear in order to intubate patients. Another thing you might notice is that they're using a videoscope rather than a traditional laryngoscope to put in a breathing tube. And the reason for it, it keeps the anesthesiologist's face further away from the face of the patient who is contagious, who is shedding virus. So it's a bit more protective. I hope you notice that in the United States, we don't have enough of this kind of gear for our own physicians. So that brings me to this sort of final section, which is our future steps. There have been a lot of people coming together to be creative, to open source, to invent. This is one attempt at an open source 3D printed ventilator. And that green thing that you see there is essentially the bag that a human would squeeze in order to drive oxygen or room air into the lungs of a ventilated patient. If we run out of ventilators, we might be able to use this contraption that they have 3D printed to actually deliver those manual breaths. This is from a company I advise for, X Biomedical, and they are working to rapidly build their first 3D printed prototype of a ventilator. So there are, again, a number of companies and inventors who are trying to work in this space. Most of the large ventilator producers can't ramp up production of their very, very, let's say their machines are much more complicated. So it's harder for them to produce more of them and manufacture more of them in time. Another thing is actually where we're going to put these people. This is from another preprint in anesthesiology, and you can see the lead anesthesiologist in Wuhan in one of their hospitals. They created new hospitals, new spaces where they could actually put people who were critically ill or who were on ventilators to isolate them from others. You can also see other things that we might be able to do. So this is an air evacuation. This is a photograph from the US military, but you can imagine that we could repurpose all kinds of things like ships and aircraft in order to create new spaces for hospitals. Here's another really good idea. There's a lot of sort of failed real estate in terms of malls, shopping malls, and things like department stores. Vanderbilt actually took over one of them and created a satellite facility for their hospital. And that is something else we might be able to do, because these things are pretty well equipped in terms of HVAC systems and power and plumbing and things of that nature. We also may want to stop having our healthcare workers constantly in such close contact with these patients. So we may start to need to use avatars or robotic doctors. VBot has an interesting thing where they have a robot that can now start IVs without any human contact. So we may find new ways to take our healthcare workers and move them away from infected patients. But you know, in the end, one of the ways that we are going to stay safe is by obeying sort of these regulations in the short term for social distancing. And if we don't follow these rules in democracies, we may have much more onerous surveillance. This is a woman in China. This went viral, this video, but there is a drone that has been following her around and that starts speaking to her because she's not wearing a mask. So the drone is telling her to go home and wash her hands. And one of the things we might want to consider is if these draconian measures need to go in place in order to ensure cooperation with these kinds of social distancing rules, the question will become, once all of this goes away, will all those measures be lifted? Another issue that I think we need to confront head on is the problem of climate change, because that's actually contributing to pandemics. And in fact, turns out that last week, China permanently banned the consumption of wild animals. So this might help with the zoonotic spread of viruses. But maybe other things like modernizing our meat production will also help. Factory farming probably is not a good thing in terms of getting humans into contact with a lot of animals that are at very, very high density. I just want to end with one final thought, and that is, in order to make these things work, you need your messaging to be very local. What works in the Bay Area is not going to work in Africa, is not going to work in a province in China, and is not going to work in Paris. So you need to tailor your narrative and your education to what every local population needs. And you also need to do it and deliver these messages from people that the population trusts. So with that, I'm going to end this part of the presentation and pass myself back to Daniel. And I thank you guys very much. And please come back and for frequent updates.
Thanks very much, Divya. I'll ask you one question. You know, so as a practicing anesthesiologist, you know how hard it is to train to be an ICU doctor, even ICU nurse. And we may be able to make more ventilators, 3D printer or otherwise. How do we upskill general doctors, regular nurses, to be able to utilize them at scale?
That's an incredible question, and there's been a lot of talk about this. I think we can first use some of our nursing staff from intensive care units and the respiratory therapists, the people who have at least seen ventilators and touched them more often, to become part of that workforce. But I think we're going to end up starting to pull people from all different disciplines from around the hospital, especially people who would normally be involved in more elective care. And we're going to have to start recruiting them and upskilling them. But we may be able to employ algorithms and machine learning to help us out with some of this. For instance, you can monitor a number of events and cases that are very critical simply by using a dashboard with an algorithm.
Right. I think we're going to have to layer these solutions together. Thanks to Dr. Chander. Stay